So I'm very happy to have you, Jackie. Thank you.
Thank you so much for having me. It is my pleasure.
You had some amazing experiences along the way. You went through the mood clinic with Beck. You researched with David Burns. You trained with 𝗔𝗹𝗲𝗅𝗍𝗍. You can make a lot of CBT people really jealous. You realize that, right?
Well, I feel as though I have been extremely fortunate in my training experiences, so that yes, I was trained by so many luminaries in the field. Yes, I just feel very fortunate.
And when did it click to you that cognitive behavior therapy made sense to you? Can you like go back and imagine how did it click?
I think that happened very early for me in my training when I was a graduate student. I was a graduate student at Penn, University of Pennsylvania, and I was interested in cognitive mechanisms of change. And I was doing research with 𝗔𝗹𝗲𝘅𝗍𝗍, who studied that topic in the area of schizophrenia. And I also worked with Jonathan Barron, who studies cognitive psychology. And then I heard about some interesting work that was happening over in the Department of Psychiatry.
Uh-huh.
And of course, it's Dr. Beck and the Mood Clinic. And so I went over there to see if they would let me participate and learn. And they were very generous to me. And I was invited to participate in some of the first didactic training for the therapists in one of the very first randomized trials of cognitive therapy, the first version of Beck, 𝗔𝗯𝗃𝗓, Cognitive Therapy for Depression, that was published in 1979. I went over in 1978,
Mhm.
so it was being passed around in mimeographed form. And then I was lucky enough to be allowed to do a practicum, and I saw some patients. And my very first clinical supervisor was David Burns. Can you imagine?
I cannot.
So David was writing Feeling Good,
Yeah.
and he gave me a few chapters so I could give comments. But this was a very exciting time, and I was immediately hooked.
I think a lot of people, especially the younger ones, but maybe all of them, are very interested to know how was it like being with some of these people. Because, for instance, what did you get or how do you remember Aaron Beck beyond the cognitive model?
The thing I would say about Dr. Beck, and I have a lot of emotion when I say this, but I have, first of all, he was very generous and welcoming when I was a graduate student to invite me to attend the trainings, and so I appreciated that very much. And then I would say that as I moved through my career and I wrote papers that would appear, fortunately, a couple of my early papers appeared in the Journal of Abnormal Psychology. And then what happened was Dr. Beck would read my paper and he would write me a letter.
Wow.
This was in the days when we wrote letters. I have some of these letters in my files to this day. He would write me a letter. He would say, "Dear Jackie, I read your paper in the journal, this and such and the other, and I think the work you're doing is very interesting, and here's my thought about it, and congratulations, and keep up the good." So I mean, who else ever does this for you? Don't you feel like you work so hard on your research, you publish the paper, and sometimes you wonder if anyone ever reads it? So Dr. Beck has this way, and it's not just me that he does this to. I think he does this for a large community of cognitive behavior therapists, researchers, and practitioners. He's encouraging and he's supportive. And
Yeah.
so I would say this is a lesson to me as I now become more senior in the field. I need to do that for the young people because it's very meaningful to me. It was very helpful to me. In fact, I got an email from him recently because I sent him a little email telling him what I was up to.
Ah.
Because I met Judy Beck at the conference, and she said, "Oh, my father likes to keep up. Perhaps you'd send him an," which I wouldn't otherwise think of doing, but I did send him an email. I got a very nice email back,
Okay.
encouraging me in my work. And even for me, a senior person at this point in my career, this type of encouragement, very important, and that's one of Dr. Beck's roles, and I think it's part of why his model has been so important and widely disseminated is because of his personal ability to provide that kind of encouragement and support.
He also seems like quite a good talent scout in a way. Uh, do you know what I mean? Like, it seems like he's able to surround himself with also very talented, very working people.
Yes, yes, that is true. And so he surrounds himself with those people, then he encourages them, and then they go out in the world and do their work and train their students. And now his influence has been international and really impossible to describe how important it is.
So, Jackie, I have to ask you, I think you committed the capital sin of cognitive therapy, which is you turned down an opportunity to work in the clinic. Is that true? Tell us that story.
You know this?
I know this.
Out.
I read around. Please tell us that story.
It's true. It's true. I had the fortunate experience of when I was a graduate student, I went over and I did practicum work, and I worked with Dr. Beck and his group, and then Dr. Burns was my supervisor. And then I applied for a postdoc, and I applied to Dr. Beck's mood clinic, and I applied to the outpatient clinic at the hospital of the University of Pennsylvania. And Dr. Beck offered me a position in the mood clinic, and I turned it down. Oh my goodness. I mean, I can tell you the reason I did it was that two reasons. One is in the mood clinic, there was no space. You had to sign up 3 weeks in advance if you wanted to go to the bathroom. I mean, literally, there was no space. And I don't know what to tell you, but whereas if I went over to the Department of Psychiatry in the outpatient clinic, where the quality of training I would get would be not as good, I could have my own office.
That was appealing.
It was essential.
Yeah.
I don't know what to tell you, but if you look at my career, you'll see that part of how I operate is I go in my office and I sit down and I think about things and I write, and I'm highly independent and autonomous. Mm-hmm. So I needed my own space, and also I needed a lot of autonomy. I wanted to be able to move around in the Department of Psychiatry. I wanted to be able to go over here and do this project with this person. I wanted to go over here, and I needed more room to move and expand my horizons. And so in a way, I felt like I got the best of both worlds, because I got some fabulous training from the Beck, from the clinic. But at the time I was doing my internship, I needed to expand my horizons, and so that's what I did.
Let me jump a little in time, because, well, I think it was in 1989 that you published your first book, the Cognitive Therapy in Practice, a Case Formulation Approach. Were you trying to fill a gap in the CBT literature in a way?
Oh, absolutely. I was fortunate enough to have been trained by Dr. Beck and by Dr. Burns, so I had learned cognitive therapy for depression. And then I found that as I left graduate school and now I'm in clinical practice, I started my practice in 1982, I'm working with depressed patients, I'm working with all sorts of patients, I'm encountering different kinds of problems that I need to solve, and I'm looking in the Beck in the manual to find the answer, and I'm not finding the answer. So, and of course, not to their fault, they can't answer all questions. So then I started thinking about how I started writing a book, which I didn't even have the idea of formulation when I started writing the book. It was just going to be some examples of problems I had encountered in trying to apply the manual and different solutions I had worked out. Yeah. And then I started thinking about the topic more deeply, and I read a lot. I did a lot of reading. I read 𝗔𝗹𝗃𝗁, I read behavioral analysis, and then I realized that the heart and soul of the answer to all of my problems is a formulation of the case. Because if you have a formulation of the case, it helps you solve clinical problems. It's a hypothesis, and you can use it to guide your thinking. Whenever you encounter a problem, you could go back to the formulation and see what it tells you about how you might solve. So yeah, I was trying to solve the problems I was encountering and trying to apply the manual. And then I found that the formulation was the answer. So
Well,
I had no idea it would turn out to be as important as it is. But it was my answer, and I'm so happy it's been helpful to others as well.
It has been immensely popular. I'm really curious about something that you mentioned, because you told, well, you learned CBT for depression. In the beginning, that was the only model, it was for depression. But you were in, were you in private practice? I believe you were? No?
Yes.
Yes. And so you wouldn't filter patients as you would in a trial, so you wouldn't just have depressed patients. So was it always a art of adapting what you already knew from the depression manual to new things that were turning up in your clinic?
Well, let me say also, in addition to my training in CBT for depression that I got from Dr. Beck and Dr. Burns, and Steve Holland was there for a while, and I learned from Art Freeman also. I also was trained by 𝗔𝗋𝗄𝗅 and by 𝗔𝗋𝗃𝗁. And so I had learned these behavioral approaches to treating anxiety and OCD. And so then I'm trying to put all these things together and treat the multiple comorbidities that are coming into my office. And, so then I found I had to think not just about disorders, treating the depression, treating the OCD, but I had to start thinking about patients, the whole patient, and all of the patient's difficulties. And I wasn't trained to do that. I mean, I figured it out for myself. Of course, what I figured out for myself, I started reading what other people had done to figure out the answers to these questions. But I wasn't trained too well to do that. And so then for me, figuring out the answer to a problem involves a lot of reading, but then I like to write about it because there's some way where that helps me get it all clear in my mind. And I think the field was struggling and actually continues to struggle with how to help the clinician treat the complex cases that are coming in the door when we have randomized trials that treat disorders. And I'm not treating a disorder. I'm treating a patient. So I got to figure out how to use what's in the literature to treat my patient, and I'd like to do that in an evidence-based way. So that's the problem I'm trying to solve. It sounds like you understand that very well.
Yeah, and tying together what you're saying, I remember in 1986 you published an article called "The Advantages of Studying Psychological Phenomena Rather than Psychiatric Diagnosis."
Wow, Alexandra, you are really...
No, I'm very curious because you published this in 86, and it seems in a way that case formulation was your answer to this as well. So were you trying to broaden this diagnosis scope a little? Was that it?
Oh, well, you're very well informed, and it is true that article, which, don't you think it's fantastic? I love that article. That article has in it the same idea that underpins my formulation book, which is let's not just think about diagnostic categories, let's think about psychological mechanisms underpinning symptoms. Now that paper came out of my research. Because I did my dissertation with Jonathan Barron, who was a cognitive psychologist. So he wasn't a clinical psychologist. So he and I were to think about symptoms and then cognitive mechanisms underpinning symptoms. And I was interested in symptoms of formal thought disorder. So I would do my research, I would write up my paper, I would send it to the journal editors, and they would all come back and the reviewers would say to me, "What is the psychiatric diagnosis of your patients?" And I was a very young investigator at the time, so first I was trying to answer that question, and then I realized, no, that if I get tangled up in that, I'm losing clarity in the way I'm thinking and in my research. So then I wrote this article about how let's just think about mechanisms underpinning symptoms, and if we think more clearly like that, we can make more progress than if we want to tie everything to these diagnostic categories. So yes, that thinking came out of my research, and I mean, you're very smart to link that thinking to my formulation book. I don't think I explicitly made those links at the time, but as you can see, it's the same type of thinking. So
yeah, and I really enjoyed that article, by the way. You were saying.
oh, thank you.
Well, is there one area in case formulation? You've trained a lot of people in it and supervised people. Is there any one area in case formulation that you see therapists, be it younger or older, too frequently not get so right? Be it the problem list or diagnosis. Is there a particularly tough spot?
I think developing a formulation is one of the hardest parts of clinical work.
Mm-hmm.
To me, the hardest part is to think about the mechanism hypotheses. And the thing I've been doing more of, certainly since my first book, and even since my 2008 book, which I'm starting to think about updating, the thing I've been doing more of, which I learned from my young colleague, Janie Hong, who was trained by 𝗔𝗹𝗲𝗅 at UBC, is to use more assessment tools, including standardized assessment tools like the Obsessive Beliefs Questionnaire, to identify, or the Dysfunctional Attitude Scale, to help the therapist identify and assess the mechanisms.
Yeah.
And so that's the thing that I think is the hardest to do.
Yeah.
And
so now you're linking the progress monitoring with the case formulation.
Well, progress monitor. Yeah, notice my first book didn't have anything about progress monitoring.
Basically, no one was doing it in a way.
Well,
Burns was
still nobody's doing it. So, but I still hadn't figured out that progress monitoring was a key element of the model, because if you're doing hypothesis testing, you got to have some data. Well, there's plenty of different types of data, but progress monitoring data is essential.
I think
and that's
your mentors in a way were very pioneers in that sense. Both Beck and Burns were one of the first ones to actually be constantly monitoring outcomes.
Absolutely. I feel I was trained to do that by Dr. Beck. When I first learned, collect a Beck depression inventory every session. What's so interesting to me, though, is then when the protocol was written, the data from the Beck depression inventory that the therapist collected, and using those data, because I was trained, collect this score at every session, make a plot, and have a visual representation of the plot that you can look at with your patient and use it to guide your treatment. That piece did not get into the protocol.
Why?
Well, I don't know. I have to ask Dr. Beck.
I wish I could.
He would do an interview with you.
That would be nice. I'll try. But, well, that's very interesting what you're saying. And you... Well, now I'm curious about another thing. I'm sorry for jumping around. But in a recent APA Handbook of Clinical Psychology, you share an early career experience where you were getting distracted in your office, and as a result, you learned the importance of collecting client feedback. Does this ring a bell, this story I'm saying?
Is that the time I was late for my patient?
Yes, exactly.
And I asked her what her reaction to it was?
Exactly, yeah. I was wondering if you could talk a little bit about this, just to segue into the importance of collecting feedback. Because as you said, this topic is sometimes, I think, not sufficiently considered by therapists.
I agree with you. Collecting feedback is very important. I would say I learned that from Dr. Beck, too. If you look at the cognitive therapy rating scale, collecting feedback from the patient is one of the things that is part of the definition of doing the treatment. So I certainly learned that from Dr. Beck, and I sometimes say whenever I give a talk that one of the main ways I have learned to be an effective clinician is from my patients. it's I read Dr. Beck, I read all these people. I had the opportunity of sitting at the feet of the giants, so I have been very lucky, and I do a lot of reading, and I talk to my patients, and I ask them, was there anything you got out of the session that was helpful to you? And this one you describe in the chapter, I got distracted in my office. I was reading something, and then at 10 minutes after 4, or God forbid, maybe it was 20 after 4, I look up and I realize, oh my God, I have a 4 o'clock appointment with a patient, and she's sitting in the waiting room, and I go out to get her, and I'm very flustered and embarrassed. But somehow I knew and so I assumed maybe she was mad or upset with me, but somehow I knew not to assume that. Maybe I was thinking about the formulation, I don't know. Anyway, so you can't assume. Anyway, so I just asked her, so tell me now, I see that I'm late. I'm embarrassed. I apologize to you. Would you tell me, what is your reaction to my being so late? She said, oh, I feel relieved. I see that you are not perfect either, and that is actually very helpful to me. So that was fantastic, good fortune for me, but it's a huge lesson, because it's happened to me many times, and I assume many experienced clinicians can tell you the same thing. Don't assume it's a mistake, or at least don't assume it's a mistake that cannot be a powerful and effective learning experience, and an experience that strengthens your working relationship with your patient. So feedback from the patient. To me, I feel as though one of the things that's helped me be a successful clinician and professional is to try at all times, which is not easy, to maintain an attitude of curiosity and willingness to learn. No matter how many mistakes you make, and I make a lot of them, as long as I try to learn and be curious, I'm going to be okay. Because you know what? I'm going to be learning a lot. So, and usually patients appreciate that kind of attitude, as opposed to getting defensive or explaining why it wasn't really a mistake, or, oh, no, it's your fault, or, oh, it's that person's. I'm not saying I never do that kind of stuff, but I try not to. And feedback is a great place to learn. So I agree with you. Feedback deserves probably more attention than it gets. Collect feedback from your patient, because there's so much we do not know about how to help our patients. Let's ask them, what's helping you here? Tell me. I'll get you more of that.
Well, I got $1 million question for you in that case, because you've been collecting feedback and data for many years now. Was there ever a situation, or maybe more than one, where the feedback and the data you collected were at odds with the cognitive theory? Did you ever get into an ambivalence?
Well, I guess the way I would say it is, I don't think the cognitive theory answers all clinical questions. Perhaps that's what you're saying. So, certainly Beck's cognitive theory was the first theory I learned, but then I went and learned other theories too. So I learned about reinforcement theory and habituation, and more recently I've been learning from 𝗵cie𝘀𝘁𝗁 and others about inhibitory learning. And I'm also learning from Marshall Linehan about emotion regulation, and I learned from Steve Hayes about experiential avoidance. So I try to use all of these theories in my work, and some of them are more helpful than Beck's cognitive theory in thinking about certain cases. So absolutely.
So the client makes you be integrative in a way.
The client does what now?
The client makes you be more integrative. He asks that of you in a way.
Oh, yes, the phenomena. Oh, yes, you're coming from the CEPI framework, aren't you?
Exactly.
Yes,
So I just gave myself away.
Okay, you told me that at the beginning. So yes, the client or the phenomena, does require me to, I suppose I'm not required, but it pushes me to expand my models and my thinkings. Absolutely.
Yeah. Well, and since we already talked about now that we put integration on the table, I've got to ask you about your take on what has been sometimes called the Dodo word verdict, and this research that it seems that most schools of therapy, bona fide schools of therapy, seem to have similar outcomes. What's your reaction to that? Your reading of the literature?
That is a complicated question. I guess I would say my first thought is that, and this is something that comes up for me when I'm talking with a new patient who comes in my office and wants treatment. And usually they're coming in my office because they want cognitive behavior therapy. But I also do feel a responsibility to provide informed consent for treatment. So I'll say, there are certainly here in the Bay Area, there are many different approaches to psychotherapy that you could choose. And I would say it is true that there's not good evidence that cognitive behavior therapy is superior to other approaches to treatments. At the same time, the sense I have is that many other approaches to treatment actually haven't been studied in randomized controlled trials. Mm-hmm. And so...
So here we're talking of a limited number of therapies. We're talking... So yeah, what you're saying is the research we're talking about is kind of limited to psychodynamic psychotherapy and some experiential therapies, but it's limited in a way.
And even I don't know very much about psychodynamic psychotherapies, but most of them haven't been studied in randomized controlled trials. Mm-hmm. I'm not saying they're ineffective. I'm just saying I don't want to be doing therapies that haven't been shown to be effective in randomized controlled trials. That's just a personal value of mine. Mm-hmm, mm-hmm. Doing them, I'm not willing to learn them. So I have a certain set of values and ideas about what type of evidence is important to me.
Sure.
So
I think it sounds pretty clear to me.
Yeah.
Actually, now that you spoke of values, I'd be really curious to ask you, if you wouldn't mind, if you were in personal therapy, how would you describe your ideal therapist?
How would I describe my ideal? Well, I need someone who listens carefully and who I feel understands my struggles, and so that reminds me of the feedback that you're talking to. So if I speak up, I want my person to listen and give me some evidence that they are understanding. And I want them to be solid and mature and reliable, and I want them to offer ideas that are helpful to me.
Would you want them to be CBT?
Not necessarily.
So it's interesting, your value there seems to go beyond the model.
It does go beyond the model, although one of the ways I think about this is that like when I think about the formulation, notice that the formulation is a formulation of the case, of the individual case, and the randomized trials have to do with the average patient treated with a certain protocol. Really what's important is this person, whether it's me or whoever it is, getting their needs met and making good progress in their treatment. I mean, I have a patient who, 2 days ago, she and I agreed we're going to discontinue. I mean, I'm providing her with the best treatment shown effective in the randomized trials, and she's not getting better. Mm-hmm. So, she's going to go off and do another kind of treatment that hasn't been shown to be effective in the randomized trials for her problem, and good for her, maybe she'll figure out something that's helpful to her. Mm-hmm. So that's the bottom line, is it helpful? But of course I'd like to see data. And so probably I should be monitoring my own progress in therapy, which is, what are my goals? and how can I monitor progress toward them, and am I getting progress? That, to me, is of course important. We can be doing the best treatment shown the most effective in the randomized trials, and if it's not helping that patient, then we need to make a change.
For me, what you're saying connects also. It's interesting that we're talking a lot about randomized trials, which are, of course, big groups of people, but I know you also have an interesting single case studies, and you contributed to the Journal of Pragmatic Case Studies. So, in the sense, there is this balance also between looking at the big point of view of what seems to be effective, but also this single case point of view.
Absolutely. Wow, Alexandra, you have read everything I ever did. I'm very impressed with you. I'd like to start with the data from the randomized trials and the evidence base more generally, the psychopathology evidence, and use those empirically supported methods and models when I'm thinking about my case. But really the bottom line is, not what is the treatment that helps the average patient with this problem, but what is helping this patient who is in my office at this moment. And can I be collecting some data to evaluate, is my patient getting better? And if not, then can I start some hypothesis testing and making some changes in the treatment plan to get the results. So yes, I'm very interested in the single case, but all clinicians are. We're interested in the patient who's in our office at that moment. So yeah, I'm trying to learn more about single case design, and more about how to. I've published two or three single cases, but I think single case studies are undervalued and underrepresented in the literature, and so that's one of my things I want to be doing next, is learning more about single case design and how to collect data to, like the very interesting question of how can you collect data from a single patient that actually has a larger contribution to make to the literature. I'm not sure the answer to that question, but I would like to find out more about it.
I think you already started giving us a clue, because going beyond the diagnosis seems important. So just taking this work you started doing, that extracting data is not just for diagnosis, it can be for case formulation, for non-diagnostic characteristics. This already seems like a good first start.
Oh, absolutely. I'm going to do a work with a UC Berkeley student next semester, and she's going to be seeing some clinical patients in my practice, and she's going to be monitoring every session symptoms and psychological mechanisms. And we're going to be looking at, and she's going to collect some physiological data as well. And so we're going to be collecting detailed process outcome data. And those kinds of data, I think, have the potential to test important hypotheses that the clinician is interested in, which is what are the mechanisms of change for this patient. And the field is also very interested in, what mechanism changes are associated with symptom changes. So the clinician has a great potential and ability to collect this kind of information over the change process that can make a contribution. So that's what we're working on.
Jackie, one trivia question. If you were on the desert island, cognitive therapy desert island, which book would you recommend to people starting to get interested in the field?
So to a young person starting to get interested in
psychotherapy and specifically cognitive therapy.
Okay.
Besides your own, that's already a given, of course.
Yeah. I'm gonna. I don't know the first book that comes to my mind, but maybe it's because it was the first book I read. Is Beck, 𝗵cie𝘀𝘁𝗁 Cognitive Therapy for Depression, which was my foundational book. Other ideas that come to my mind are Judy Beck's Basics and Beyond, and my other foundational book was David Burns's Feeling Good. So, sorry, that's three.
That's a holy trinity of cognitive therapy in a way.
Yeah.
Jackie, I would like to finish off by asking you a question that I've asked all of our colleagues, which is, if you were starting out now, what advice would you wish to have received when you were starting out as a psychotherapist?
What advice would I have wished to receive when I was starting? I guess what I would have liked to be told and to understand in a way that I only figured out later was the idea that patients are very tolerant of mistakes. Because I tend to be a little bit of a perfectionist, I'm always trying to do the right thing. And it's not really necessary. I mean, we do want to work hard for our patients and try to, but mistakes or things that I would tend to consider mistakes actually are hugely powerful potential learning experiences, both for the patient and the therapist. So it's not so important to never make a mistake. I was so amazed at how forgiving my patients were of my mistakes, number one, and also of how much could be learned from mistakes. So I would like to remind young therapists just starting out of the power of learning from mistakes so as to help them feel less anxious about making those mistakes.
Jackie, I think that's a great way to finish. So let me just thank you for the opportunity of talking.
Thank you, Alexander. It's been a pleasure to talk with you. You're so thoughtful and have read so widely that it was very stimulating for me to have this discussion with you.
Thank you so much.